Hello, I'm Tiffany Hall, a patient blood management specialist, and most recently was the clinical director of patient blood management at Florida Hospitals in Orlando, Florida. I joined the Florida Hospital team in January 2013 to develop and implement a comprehensive patient blood management program at the 8 campuses for Florida Hospital System. Prior to joining Florida Hospital, I was a patient blood management coordinator and assisted in the program development and implementation of the PBM program for Eastern Maine Medical Center in Bangor, Maine. I currently serve as a board member for the Society for Advancement of Blood Management, which is responsible for providing you this learning activity. First, let's review our learning objectives. To describe the optimal leadership and structure essential to PBM program success and sustainability. To identify hospital stakeholders for engagement. To explain the use of metrics and give examples of quality indicators to monitor the impact of various PBM modalities. And to cite reimbursement needs and opportunities. The Society for the Advancement of Blood Management, SABM, Patient Blood Management Program Standards, outlines the key elements to a strategic implementation. The very first standard addresses leadership and program structure. Standard 1 states, there is an effective organization-wide, patient-centered patient blood management program. The program has a physician medical director to provide clinical leadership and oversight, and a program manager to provide operational leadership. The program has a defined scope of service, mission, vision and values, policy and procedures, clinical protocols, educational programs for healthcare providers, and review of patient outcomes. Standard 1, as stated, defines the program. The guidelines and indicators become the backbone of a comprehensive patient blood management program. We're looking at a chart from the Executive Guide 2.3, Optimal Reporting Structure. Optimal leadership and program structure is essential to the successful implementation of a PBM program. Without these two important elements, the solid foundation of an effective, patient-centered, comprehensive patient blood management program cannot be established. This slide illustrates the strongest reporting structure to best initiate and sustain quality and performance improvement projects in the hospital administration. In the next few slides, we're going to identify hospital stakeholders for engagement. This is a chart from the Executive Guide 2.4, Key Stakeholders Clinical. Successful implementation of a comprehensive PBM program requires engagement of key stakeholders and PBM champions. The stakeholders will help determine strategies consistent with the institutional goals and align with the SABM PBM standards. Identification of key stakeholders can be grouped into 3 categories: promoters of change and PBM concepts, physicians identified from areas of highest opportunities based on transfusions that are ordered out of guidelines, and teams or areas needed to support the PBM program implementation, such as nursing, information technology, pharmacy, and finance. Let me emphasize, nursing is crucial to the promoter of the team. These key stakeholders and champions should be the members of the PBM committee. Another key requirement is finding the right people to lead the program. The medical director position requires an influential physician who is knowledgeable and experienced in the use of blood components and is knowledgeable of PBM concepts, principles, and modalities. The medical director will serve as a PBM consultant to medical staff and as a liaison to appropriate medical staff committees. The medical director will also need to take responsibility for developing PBM educational content, including CME programs for medical staff. The program manager or clinical director also needs to be influential and adapt to change management. Both need to have prior knowledge and experience in transfusion medicine or patient blood management. The program manager is responsible for navigating the healthcare system, managing day-to-day operations of the PBM program, providing guidance and education to staff, demonstrating a working knowledge of PBM principles and concepts, and facilitating PBM quality and performance improvement initiatives, which include strategies to work on modifiable risk reduction for transfusion. Lastly, physicians and program managers are identified as having not just authority, but most importantly, the responsibility for a quality PBM program. Thus, these leadership roles are not to be taken lightly. In addition to program leadership, having strong support and buy-in by senior hospital leadership is key to the program's growth and success. The senior hospital leadership will assist with financial support for program development, provide influential support with program adoption by high utilization providers, and remove barriers and open doorways during the crucial healthcare navigation. The senior leader support, as the executive sponsor, will need to be visible to all key stakeholders as strategic plans are being implemented. It is also imperative that the patient blood management program is supported by a defined management structure in the organization. The program also needs to be appropriately positioned within the organizational structure to reflect strong administrative support of the program. Since the concept of patient blood management focuses on risk mitigation, many programs are positioned to report to patient safety and/or quality, then up to the chief medical officer for the hospital. Over the next few minutes of this presentation, we will address the third learning objective, to explain the use of metrics and give examples of quality indicators to monitor the impact of various PBM modalities. Identifying key metrics and quality indicators will assist the patient blood management program to align their quality improvement programs using the framework of the SABM patient blood management standards, thus effectively measuring program quality, monitoring adherence to the SABM patient blood management standards, and monitoring the impacts of patient blood management modalities, and equally important, to evaluate the program for performance improvement opportunities. This slide illustrates the available resources: the Society for Advancement of Blood Management Clinical Standards for Patient Blood Management Programs and the Society for Advancement of Blood Management's Quality Guide. Both are available from the Society for Advancement of Blood Management website at sabm.org. There are three types of measurements to effectively monitor the impact of the program: blood utilization metrics, PBM quality metrics, and key performance indicators. There should always be opportunities to improve as a program evolves, hardwires processes, and meets improvement strategies. These can all be found in the SABM Executive Guide. As the patient blood management program begins to identify their measurement goals, it is important to track and report on data that can impact change. First, metrics looking at blood utilization will need to be evaluated, and an effective PBM program with strategies implemented should see a reduction in usage. These are some of the examples of utilization metrics that can be tracked: transfusion rates by service line, transfusion practice by physician, number of blood component units transfused, percentage of single unit red blood cell transfusions, units transfused per 1,000 patient days, average hemoglobin and hematocrit before and after transfusion, and use of decision support tools and guides. This slide illustrates one such metric: red blood cell units transfused per 1,000 discharges, and demonstrates a significant reduction in red cell component achieved at Eastern Maine Medical Center over a 2-year period. On average, a program can expect to see a 30 to 40% reduction in 5 years. In my own experience with Eastern Maine Medical Center, we achieved a 58% reduction in 4 years. Tracking units transfused by product per 1,000 patient days and by service lines and provider will be helpful to identify where to focus additional education and strategies to support reductions. This published paper reported the various patient blood management strategies implemented having the strongest impact on improving blood utilization and subsequent reduction: meticulous surgical technique, goal-directed coagulation algorithm, along with more restrictive transfusion threshold. These are some of the PBM strategies presented earlier in Module 1. Secondly, as the patient blood management program continues to evolve and grow, the metrics should be more specific, patient-centric, and focus on quality. Quality metrics should look at transfusion-related outcomes, such as length of stay, ventilator times, ICU stay in transfused versus non-transfused patient populations, evaluations of infection rates in transfused versus non-transfused populations. Metrics specific to anemia management will also help support the patient blood management goals of risk mitigation within each hospital. One best practice recommendation would be to share with key stakeholders during a board meeting a patient story or a case study illustrating an important outcome as a direct result of the patient blood management initiative. One can find a list of the 16 PBM metrics in the SABM Executive Guide at sabm.org and how they can align with hospital quality, safety, and financial goals. This is a chart from the SABM Executive Guide 3.3 from PBM metrics to key performance indicators, example 1. So thirdly, it is vital to measure the impact of the program using key performance indicators set by the program leadership. One suggestion is to assess the impact of transfusion on length of stay using specific DRG or diagnostic rate group. If the hospital has a preoperative anemia management program for elective hip and knee replacement in the orthopedic service, length of stay can be compared in transfused versus non-transfused patients before and after preoperative anemia management implementation. This key performance indicator will evaluate the effectiveness and the impact of the program specific to transfusion avoidance, length of stay, and patient outcomes. This slide shows a poster used as part of a hospital-wide education strategy to advance a PBM metric or key performance indicator, focusing on single-unit transfusion. The single-unit transfusion metric made a significant contribution to the reduction in red cell usage and improved anemia management at both my previous hospitals. In my own experience, I've seen the single-unit transfusion metric go from less than 20% to greater than 75% in a period of 4 years. In the final few slides, we're going to cover our last learning objective for this lesson, to cite reimbursement needs and opportunities. One of the Society for Advancement of Blood Management's 4 guiding principles is evaluation and managing anemia. As part of a comprehensive patient blood management program, anemia is managed in the outpatient setting. Treatment of anemia in this setting can be limited based on reimbursement and insurance restrictions. Most commercial insurance providers require prior authorization for the use of IV iron and ESA therapy. Insurance approval can take up to 7 days, which cuts into the 3 to 4 week preoperative optimization window. This delay may reduce the patient's response to treatment and promote the need for a blood transfusion. The information presented in this slide comes from the Society for Advancement of Blood Management brochure, Emerging Evidence on Anemia, Evidence, Education, and Better Patient Outcomes in 2016. Coverage restrictions with Medicare are oftentimes more frequent than with commercial providers. Reimbursement is managed by Medicare Administrative Contractors, or MAC, and National Government Services, NGS, which limits the coverage of intravenous iron using medical policy articles. The first restriction requires that patients fail an oral iron trial before intravenous iron will be covered. The delay can also limit the treatment time for a preoperative patient by 2 to 3 weeks. The second restriction does not allow for ESA and intravenous iron to be administered on the same day. This is a challenge that impacts the patient's time and treatment outcome. The restriction often requires extra clinic visits to get the patient fully optimized, which results in added cost and a drain to the healthcare system. The third restriction limits the treatment of iron deficiency without anemia. In addition to the IV iron restrictions, many Medicare administrative contractors limit the pre-surgical use of ESA therapy with orthopedic patients only, when many more patients having other high-risk blood loss procedures would benefit from preoperative hemoglobin optimization to avoid the need for transfusion. Prior to implementing a patient blood management program, each hospital needs to thoroughly investigate their own state coverage guidelines and potential restrictions to the use of intravenous iron and ESAs in their patient populations. In summary, we have provided a brief overview of the following essentials needed to organize and implement a patient blood management program. Optimal leadership and program structure is essential to the successful implementation of a patient blood management program. Engagement of key stakeholders and patient blood management champions is vital for changing culture. Identifying key metrics and quality indicators to align with the SABM PBM standards improves quality and operational performance. And it is important to understand state coverage for patient blood management interventions by local medical use policies. The Society for Advancement of Blood Management has made the following resources available to you at sabm.org. Thank you for allowing me this opportunity, and I commend you for your interest and support of this very important mission and concept. On behalf of the Society for the Advancement of Blood Management, we wish you the very best success in your patient blood management endeavors.